Is everyone seeing that okay?
Yes.
Perfect. I'm just gonna minimize you. Great. Good morning, everyone. My name's Carolyn, and today I'll be sharing about internet use and the risk of dementia. I have no conflicts of interest. Imagine that you're at the dinner table and telling either your real or hypothetical teenager to get off their phone. They tell you they're preventing their own dementia and show you this news headline. In addition to saying, "Show me the evidence," what else will you say about why this finding may be less than believable? Let's see if we can form a rebuttal together by taking a closer look at the source article. The objectives for today are to outline the relationship between internet use and cognition, to discuss methods of dealing with selection bias and reverse causality, to critically appraise the study, and to consider implications for daily practice. In Canada, about 70% of older adults use the internet regularly. Prior research has found that internet users may have better memory, verbal reasoning, and overall cognitive performance than non-users. Proposed reasons for this include increased social connection, cognitive stimulation, motivation to learn new skills, and access to health information. Existing research consists of cross-sectional analyses and longitudinal studies with short follow-up periods, leaving long-term cognitive benefits of internet use unexamined. The objective of this population-based cohort study, published in May 2023, was to characterize how internet use is associated with the prospective risk of dementia. The authors included community-dwelling participants aged 50 to 64 at baseline without dementia. Data was from the Health and Retirement Study, which is an ongoing longitudinal study of US adults aged 50 plus. Respondents are followed every 2 years by phone or in-person interviews until death or attrition. The exposure was regular internet use, which was dichotomized based on participants' answers to whether they regularly use the internet for any purpose. The outcome was incident dementia diagnosed based on the Lango-Weir classification, a widely used method for identifying dementia in HRS participants. It uses cutoff scores to classify individuals as either having or not having dementia based on either a self-completed TICS-M or a proxy report on memory, IADLs, and overall cognition for those who cannot complete the TICS-M. The authors excluded potentially eligible participants because they did not report internet usage, did not complete the baseline TICS-M, or because they did not reside in the US, which were their main exclusion criteria. A further 1,320 were excluded due to missing data on outcome or covariates, such that their final cohort comprised 18,154 adults. The association between time to dementia and baseline internet use was examined using cause-specific Cox regression. The authors controlled for baseline TICS-M score, self-reported health, age, household income, marital status, region of residence, use of proxy, and imputation of cognitive assessment data. To help address selection bias and the presence of confounders, they use inverse probability of treatment weights, IPTW. To address reverse causality, that is, dementia contributing to less internet use, they also analyzed a subsample who did not have any evidence of cognitive decline at 2 years. In addition to the main effects of baseline internet use, they examined its interactions with education, race, ethnicity, sex, and generation. They also performed sensitivity tests to check for reverse causality. First, they performed an analysis limiting the sample to people younger than 55, as younger participants are less likely to have undetected cognitive impairment at baseline. Second, they used different lag times for study entry ranging from 0 to 8 years. This helps remove the impact of dementia diagnosed shortly after study entry, as these early events are more likely to contribute to reverse causality. And lastly, they explored variations in dementia risk based on degree of internet use in 2 ways: cumulative waves of usage and daily hours of internet use. Here we see the characteristics of the included participants by baseline internet use. At baseline, 65% were regular internet users, median age was 55, and the median TICS-M score was 17. Median time in the study was 8 years. Unsurprisingly, the percentage of regular users was higher among non-Hispanic whites and increased noticeably with younger generational cohorts, higher education levels, greater household income, as well as better self-reported health. And about 14% of non-regular internet users experienced the competing outcome of death without dementia, compared to only 5% of regular users, suggesting differences in baseline comorbidities and frailty, which were not included as covariates. Given all the differences between regular internet users and non-regular users, IPTW was used to balance characteristics in the two exposure groups. And as mentioned in the discussion at our July Journal Club, it is good practice to reassess the balance in baseline covariates after applying the propensity score, which is illustrated in these figures. The figure on the left illustrates how regular users appeared to have a lower cumulative incidence of dementia than non-regular users at a given age. On the right, we have the same analysis, but including only those without signs of cognitive decline 2 years after baseline. The authors found that regular internet use was associated with approximately half the risk of dementia, with a cause-specific hazard ratio of 0.57. Similar values were obtained with IPTW and in the subsample without evidence of cognitive decline at baseline. The association did not vary significantly by educational attainment, race, ethnicity, sex, and generation. Notably, an analysis by income level is absent here. They did find that each additional wave of internet use was associated with a 20% decrease in the risk of dementia. And they also found that a U-shaped relationship between daily hours of use and dementia incidence. However, I note that none of these findings were statistically significant in the context of small sample sizes. The authors concluded that regular internet users experience approximately half the risk of dementia compared to non-regular users. Therefore, moderate online engagement in older age may help sustain cognitive function. So with this, you can tell your real or hypothetical teenager that they should put their phone down because they're not in the right age group for the study. But what about our patients? What will we tell them? We'll need to appraise the study to find out. The first domain of Robbins E is the risk of bias due to confounding. In terms of unmeasured confounders, I would have liked to see information on employment status, depression, vision impairment, smoking and alcohol use, comorbidities, overall frailty, and social supports. IPTW cannot address the problems that arise from these unmeasured confounders. There is also the concern of reverse causality. Common methods to account for reverse causality include removing individuals with prevalent disease and use of longer follow-up periods. This helps reduce the proportion of participants where dementia likely developed first and contributed to less internet use. As previously mentioned, the authors used various methods to address reverse causality. However, it is difficult to fully exclude the impact of reverse causality, and given the unmeasured confounders, I gave the study a high risk of bias in this category. The next is risk of bias due to exposure measurement. I had some concerns here, given that exposure status was determined by participant response to a single question with room for varying interpretations of what constitutes regular use. For risk of bias due to participant selection, IPTW was used to balance covariates, but given how different the groups were at baseline, I'm concerned that this remains an important source of bias. Risk of bias due to post-exposure intervention was low, as there were no known interventions that would have been administered to alleviate the effects of exposure status. For risk of bias due to missing data, at first glance, 7% of participants with missing data seems fairly low. However, for dichotomous outcomes, we need to consider this value relative to the number of outcomes. The number of participants with missing data actually exceeded the participants who experienced the outcome of interest, which leads to some concerns in this domain. And lastly, for risk of bias due to measurement of the outcome, proxy reports have been shown to be more sensitive for dementia diagnosis than the TICS-M, and non-regular internet users were more likely to use a proxy. So overall, I gave this study a high risk of bias. Strengths of the study include the attempts made to account for reverse causality and selection bias, along with the duration of follow-up, which is the longest among existing research on this topic. And even though we have reason to be wary of the validity of their findings, I think they have the potential for positive impact if they contribute towards improving internet access and digital literacy among older adults. Limitations include the potential impact of selection bias and reverse causality, despite their efforts to address these, as well as the suspected presence of unmeasured confounders. The cohort was also fairly young and therefore had lower incidences of dementia, which limits the applicability to our patients. There are also some concerns about exposure and outcome measurement, as the Lango-Weir classification lacks complete concordance with clinical diagnoses of dementia. And furthermore, the relationship with MCI was not evaluated. I also think that this line about how they found no evidence that the internet contributes to socioeconomic disparities in the burden of dementia is potentially misleading, given that they did not examine the interaction with income. And lastly, we are lacking information about the type of internet use, which seems important from a clinical point of view, as spending 6 hours planning a multi-country trip or taking an online course is very different from watching 6 hours of Grace and Frankie. Practically, when it comes to non-pharmacologic strategies for dementia risk reduction, I think it makes more sense to focus on the goal, that is increased cognitive, physical, and social activity, instead of being overly prescriptive on the method of achieving that goal. And based on this study, I'm not yet convinced that the internet should be recommended over other activities for dementia prevention, though it is certainly helpful for everyday tasks that can help older adults remain independent, especially during a pandemic. So the bottom line, what can we tell our patients about the internet? Well, whether it'll make you less likely to forget and delay the time to dementia onset, we haven't quite made up our minds yet, but learning to use it is certainly an asset. Whether you are reading Romeo and Juliet, watching the Netflix series Selling Sunset, listening to a Beethoven minuet, learning a new recipe for vinaigrette, or even taking care of a virtual pet. The options are as endless as government debt. Just please do not go on fanfiction.net. Those are my references, and thank you very much for listening.
Wow, Carolyn, that was great. Particularly, I didn't count the syllables, but if those were limericks, if they qualified as limericks, that was fabulous, entertaining, and greatly enjoyed the detailed description of your critical appraisal rather than simply yes or no statements on the bias. So thank you very much for the wonderful presentation. I'll open it up to the audience for questions or comments. Any in the chat? Go ahead, Shabir.
Great presentation, Caroline. I just want to make 2 comments around the study, and I think you did a great job with critical appraisal. In terms of the items on Robin E., there is one that I think I may disagree with you on, which is whether there was a risk of co-intervention that was different between the groups, because although we know there are no treatments to treat dementia at this stage that have really been proven in a convincing way, we definitely have evidence that there are preventative strategies, such as modifying cardiovascular risk factors, that may reduce the incidence. And they don't really report in the 2 groups whether people who are regular internet users or not were more likely to seek out preventative maneuvers, such as controlling blood pressure particularly, and other strategies that have been shown to reduce the incidence of dementia. So that is a potential co-intervention that we don't know about. And then the other point I'll make is that whenever you dichotomize outcomes such as exposed or not exposed, you're really simplifying a complex relationship. I would have loved it if the authors had a more rich way of measuring internet, and you commented on this in terms of type of exposure and what do they watch and what do they do and how engaging. But even in terms of hours, if you could demonstrate a linear relationship that is more powerful in terms of potential causation or contribution than simply yes, no exposure. So if they had, for example, quintiles of exposure and you could clearly see a gradient, that is one of the things that is supportive in terms of epidemiologic principles around the association. And so that was another area that I think is important to think about when analyzing these kinds of studies, but great presentation. I think Christina wanted to follow up on something I just said.
Thank you, Shabir. Carolyn, do you want to respond, or I will read Christina's comment?
Yes. I can respond one at a time.
Yeah.
Thank you so much. I completely agree about the post-exposure interventions. In my mind, I incorporated that into some of the selection bias and baseline covariates, which might alter some of those behaviors as well. But I agree it should have been included in the post-exposure interventions as another source of bias. And to the second point, I think that really speaks to the limitations of using the health and retirement study data, because a lot of that information was not built into the survey. So the authors did do the extra sort of off-year survey with some information on number of hours. But sort of linking to Christina's question, they had a much smaller sample size. Therefore, they were only able to make limited conclusions. But the U-shaped association was interesting because I think that sort of empirically, thinking about this before reading the study, a U-shaped association does make sense. And I would expect that's probably the case for other age groups as well. But I think that given the small sample size, it's difficult to know how much stock to take in this. And I do wonder about the influence of unmeasured confounders on this. For example, depression and other covariates which may be associated with dementia, which may be responsible for some of the more negative outcomes at the higher end of this exposure.
Thank you. Did they have a theory on what was the effect of internet usage?
They did not discuss this explicitly, but they did sort of cite previous studies which found proposed reasons like increased social connection, cognitive stimulation, access to health information, things like that. They noted that this has been studied more so in younger populations, where it's been found that internet use may actually be harmful for cognition, but that with older adults, it may be a very different picture.
Thank you. Any other comments or questions from the audience? Perhaps the last question, you mentioned an acronym IPTW, and perhaps for the audience, just to clarify, IPTW?
Yes. So IPTW, inverse probability of treatment weights. So it's a method that's used in observational studies to help balance your two exposure groups. So in this case, we know that people who are baseline internet users and those who are non-users are likely very different. And we saw that in their table 1 as well. So IPTW helps balance different characteristics. The issue with IPTW is that it only balances what the covariates that the authors measure. So in this study, things like employment status, depression, alcohol use, and smoking, factors like that were not measured and therefore not balanced in IPTW.
Thank you.
And IPTW can reduce residual confounding by over 90% among the variables you can measure. Among unmeasured variables, it is much less likely to be effective in reducing residual confounding, which is part of the problem. If you haven't measured it, it's hard to balance it out and adjust for it without randomizing.
Thank you.
Thank you. If there are any further questions or comments to Carolyn, please enter them in the chat function. We will move on to our second presentation of the morning, Dr. Victoria Chuen, to present on predicting delirium in perioperative, postoperative patients. Victoria, we can see your slides.
Okay, great.
And we can hear you well. Thank you.
Okay. Hi, everyone. So today I'll be presenting on the paper titled Development and Validation of an International Preoperative Risk Assessment Model for Postoperative Delirium. This paper was just published recently in Age and Aging in June of this year. I have no conflicts of interest to disclose. So for our objectives today, we'll briefly review the literature on assessing the risk of postoperative delirium in surgical patients. We'll then summarize the methodology and the key findings of this journal article. And then finally, we'll focus on the critical appraisal of this paper.
Sorry, Victoria, to interrupt you. On my end, the slides appear to have frozen.
Oh, no.
So that's better. We can try again.
Okay.
Okay, go ahead.
Okay, so the incidence of postoperative delirium in surgical older adults is reported at 10 to 50%, depending on the surgery type. And we also know that postoperative delirium has been shown to be associated with a number of adverse outcomes for our patients. This includes an increased length of stay, increased mortality rate, rates of institutionalization, patient and caregiver distress, as well as delayed functional recovery and long-term cognitive decline. And in fact, delirium is reported to be preventable in 30 to 40% of patients who are at risk by using preventative interventions. And therefore, it's crucial to identify patients who are at risk prior to their surgery so that we can appropriately implement strategies to reduce the risk of delirium and, of course, the negative sequela that follows. And so it's also important for educating patients and their families in understanding the potential associated adverse events related to their surgery as well. And
so I'll have to interrupt or stop you again. It's frozen on our side. Can I have a thumbs up? Is it just my screen or it's the group as a whole that's...
There's an overlay of some of the previous images.
There's an overlay. So Victoria, I don't know if you want to try and reload, or I have the presentation in PDF I can scroll through.
It refreshed itself now. The current slide looks normal.
It's on changing slides. It takes longer than your
maybe
presentation.
For the sake of, maybe for the sake of technology, we could, if you could share for me.
Okay,
and then,
I will do that.
Thanks. I'm just on, slide 5. And I will stop sharing.
Okay, if you stop sharing.
Thanks for that.
Can you see my?
Yes.
So we're slide 5?
Yes. All right.
And you just let me know when to forward.
Okay, perfect. And so effective interventions to preventing delirium include involving caregiver support, implementing a multi-component non-pharmacologic intervention or formalized help or hospital elder life program, and consulting a geriatrician for a comprehensive geriatric assessment by way of a proactive CGA. Next slide. And so given the impact of postoperative delirium and the potential to intervene for those at high risk, the development of a postoperative delirium risk assessment tool has been an ongoing area of research and development for many years. Back in 1994, Mark Antonio and his group developed a clinical prediction tool for assessing the risk of postoperative delirium. They had included patients aged 50 years and older undergoing an elective non-cardiac surgery under general surgery, orthopedics, or gynae. And on the left side of the slide here, you can see the variables that they accounted for in their risk assessment tool, which includes age, alcohol use, poor cognitive status as measured by a TIC score less than 30, poor functional status, abnormal serum sodium, potassium, or glucose level, if they were undergoing a non-cardiac thoracic surgery or surgery for aortic aneurysm. Next slide, please. Another postoperative delirium risk prediction tool was also developed from a patient population of individuals aged 65 years and older undergoing elective hip or knee arthroplasty. This tool uses age, cognitive impairment as defined by the MMSE score, history of substance use, IADL dependence, and sensory impairment. And this model had an area under the curve of 0.77. A cutoff of 2 or more points has a sensitivity of 61% and specificity of 76% in predicting postoperative delirium risk when compared to the gold standard of using the CAM assessment to detect delirium. The model was then validated in a population of older adults with hip fracture undergoing surgical repair. And in the external validation group, fairly different results were found with a cutoff of 2 giving a sensitivity of 93.2% and specificity of 41.8%. Next slide. And so while I have only shared 2 of many tools, critique has been received on some of these tools in that they were developed using patient populations undergoing just a specific surgery type, or that the populations used to externally validate these tools were also limited in their population type. And this can potentially limit the translatability of the tools to a broader surgical population across different surgery types or levels of acuity, such as elective versus emergent surgeries. Additionally, many studies were dependent on retrospective data from hospital records, which do tend to underestimate the incidence of postoperative delirium due to the inadequate documentation of delirium in hospital charts. Next slide. So now we'll move on to our paper. Next slide. In light of some of the limitations of previously developed tools, the researchers of the study aimed to develop a tool to be used in the preoperative setting to identify the risk of postoperative delirium across a broad range of surgical patients. The condition being assessed is postoperative delirium, as defined by the DSM-5 criteria, which uses the standard definition of delirium, but specifies the time frame of presenting within 1 week postoperatively or until the patient is discharged. The context was the postoperative setting for patients undergoing either elective or emergent surgery across different surgical types, but excluded cardiac and intracranial surgeries in hospital. And finally, the target population was for patients aged 60 years and older. Next slide, please. In order to establish a large population of patients to develop their risk model, the authors performed a systematic review of risk factor studies with an outcome of postoperative delirium. In their search criteria, they looked for studies that assessed for preoperative risk factors of delirium and that at a minimum assessed patients for postoperative delirium in the first 2 days postoperatively using a validated tool for diagnosing delirium. They identified a total of 192 studies, but only 21 studies had agreed to share their individual patient level data. They excluded studies where the outcome assessed for other types of delirium and studies including patients undergoing cardiac or intracranial surgery, as that can affect the pathophysiology of postoperative delirium. At the patient level, they excluded patients less than 60 years old who did not have a reported postoperative delirium outcome and those who had developed delirium preoperatively. Next slide. They were then left with a total of 8 studies that could be used in their model development. 6 were cohort studies, 1 RCT, and 1 large prospective study. Of these studies, 4 were hip fracture studies, 1 for patients undergoing major surgery, 1 for urologic surgeries, and 2 for elective colorectal surgeries. The tool used to assess for postoperative delirium was variable, as you can see, but all had previously been validated for detecting and diagnosing delirium. I also want to point out where I've underlined that 3 of the studies excluded patients who had baseline cognitive impairment from their sample population. Next slide. In order to develop the risk algorithm, they then considered risk factors that were selected based on prior literature review and clinical knowledge. They assessed for the availability of these risk factors in the selected studies and had only selected variables that were present in at least 3 of the 8 studies, and that would also be available to clinicians in the preoperative setting only. Comparing between individuals who did and did not develop postoperative delirium, they performed an unpaired two-tailed t-test to identify differences in clinical parameters between these 2 groups. They identified 9 clinical parameters that differed and ended up using these to train the postoperative delirium risk prediction algorithm. Because some of the variables were not available across all studies, the authors addressed any missing data by reconstructing the data point using other available variables. So for example, calculation of the BMI using the height and weight, or determining the ASA status based on the reported comorbidities. However, not all variables could be reconstructed from other reported data. And so for other missing variables, they performed something called single imputation by using the predictor average for any numeric variable and the mode for any categorical variable. And this essentially involves estimating the missing value by replacing it with a single value in the data set. Finally, to develop their model, they considered a range of analyses and ended up using a logistic regression with L1 penalty in order to prevent overfitting. Next slide, please. To internally validate their algorithm, they performed a 10-fold cross-validation for the assessment of discrimination as measured by the area under the curve and also for calibration. 10-fold cross-validation essentially separates out their data into 10 different groups. And then you can see that for each group, 1 group is kept as a testing data set, and the remainder are used as training data set. The training data set is meant to be applied to the model, and then finally at the end, you would use the testing data set to evaluate the model. Next slide, please. Once the variables and models were established, patients could then be stratified into 1 of 4 risk threshold groups, ranging from low to very high risk of postoperative delirium. To distinguish those at low risk from all others, on the left-hand side of the slide, they aimed for high sensitivity so that you could confidently rule out postoperative delirium risk, whereas the cutoff Between very high risk individuals and others, they aimed for high specificity so that you can more confidently rule in delirium risk. In the middle, they tried to establish a balance between specificity and sensitivity. Next slide. Once the model was developed, they then externally validated their tool using a separate data set completely independent of their initial model development. They took data from two different studies. One was an internal quality control study, which involved prospective data collection from a 70-bed orthopedic and trauma department. And patients in the study were assessed for postoperative delirium using the delirium observation screening scale. The data from the second study actually came from an RCT that was conducted by the same authors of the study, where the study was also intended to collect data for the external validation of the study. However, it's not clear in the manuscript what the RCT was designed to study. However, patients in the study were assessed for postoperative delirium using the 4AT tool or the CAM-ICU if patients were intubated, and they included all non-cardiac surgical patients from the study. Next slide. So now we'll move on to our results. Next slide. In total, they included 2,250 patients in their training data set, where 19.7% had delirium. Interestingly, apart from sex, they primarily only reported the results of the clinical variables, which they found to be significantly different between those who developed and did not develop postoperative delirium. These were the variables that ended up in their risk assessment model, and they presented no other baseline characteristics. It's unclear whether this is because of the variability of data reported across studies or for other reasons. You can see highlighted in red is the amount of missing data across the studies for the variables that were selected, including a history of cognitive impairment, history of delirium, the preoperative CRP level, the number of medications patients were on, the type of surgery, and the related risk to the surgery. Next slide, please. According to the authors, when they reviewed the literature, over 140 variables were initially considered, but they ended up selecting only clinical parameters that differed significantly between patients who developed postoperative delirium versus those who did not. As detailed in the previous slide, the preoperative CRP level was not always available, and so the authors actually created two different models, one with and one without CRP, so that it could be used as an optional variable. Therefore, variables included the patient's age, the surgical risk for cardiac events, patient's BMI, the ASA status, whether the surgery was a laparotomy or thoracotomy, the underlying cognitive status or cognitive impairment, which they defined as an MMSE score less than or equal to 23, or if the prior studies had identified it as yes in binary terms, the number of preoperative medications, a prior history of delirium, and then plus or minus a CRP level. On the right here, you can see the proportion of individuals who fell into each category, with a majority of patients being at low or medium risk of postoperative delirium. Next slide. So this is a classification plot of the model with CRP in blue and then without CRP in red for the development data set, which depicts the cutoff thresholds for defining low, medium, high, and very high risk patients for postoperative delirium, which is organized by the color in the background of this plot. The plot is essentially a visual depiction of the sensitivity and specificity at each risk threshold level. And you can see that the models with and without CRP are very similar in their ability to distinguish risk of postoperative delirium in the training data set. In order to attain high sensitivity for those at low risk of delirium and high specificity for those at high risk of delirium, we see that a threshold of 10% or less was set to be considered as low risk, with a high sensitivity of 90%. And on the other end of the spectrum in the red area, at those who are 35% risk or higher, there is a 92% specificity to rule in postoperative delirium risk. In the middle, a threshold of 20% differentiates medium and high risk, with a balance between sensitivity and specificity at 68 and 77% respectively. Next slide. Now briefly discussing the performance of the risk prediction model during the development stage. The full model, which includes the preoperative CRP level, and the model without CRP both had an area under the curve of 0.81. At internal validation, the algorithm had an area under the curve of 0.8 with CRP and 0.79 without CRP. And generally, the area under the curve is a way to summarize the overall accuracy of a test, where a value of 0 would mean that it's very inaccurate, and a score of 1 would mean that it's perfectly accurate. So you can think of an area under the curve of 0.5, meaning that there is really no ability to differentiate those with and without the disease. A score of 0.7 to 8 is acceptable. 0.8 to 0.9 is considered excellent, and then over 0.9 is outstanding. Now moving on to their external validation sample, sorry, next slide, which as a reminder was derived from 2 separate studies. They had a total of 359 patients in the external validation sample. And you can see generally that these patients tended to have higher BMI and ASA scores, and they also tended to be on more baseline medications. Additionally, no patients had undergone a laparotomy or thoracotomy, and no surgeries were considered high risk for cardiac events. There were also missing data, particularly 81% of individuals who did not have a preoperative CRP level. And the authors reported that they reconstructed data for the ASA and BMI scores, but it was not clear what was done to address the other missing data as compared to the single imputation that was done for the training data set. Next slide, please. The external validation yielded an area under the curve of 0.74 compared to 0.81 using the training data set, and was the same for both models with and without CRP. This showed only a small decrease from the internal validation model, which had an area under the curve of 0.8. The authors did not report specific sensitivities and specificities, but you can see that at the 10% risk threshold in the green area, the sensitivity is about 80%, and at the 35% risk threshold for high risk, the specificity is about 87%. In terms of the calibration curve shown on the left side, you can see that there's good calibration for patients at high risk in the red area that's shaded, and some underprediction for those in the lower predicted scores, where you see that the model deviates from the white line, which essentially shows what you would have if you had good calibration. The average risk of the group at the lower risk categories tended to be even lower than what would be predicted by the model. Next slide. The authors then developed a user interface software, which are like many risk calculators that we're familiar with, say on MD-Calc or ePrognosis, that allow you to input various pieces of data and then generates a risk assessment. The impact of an individual risk factor on the overall risk is shown in comparison with the average for continuous variables or the most common for the categorical variables. Of note, the authors certified the software for medical use in Europe, resulting in it being considered now a Class 1 medical device with CE certification. The caveat with this being considered a medical device is that access to the tool is monetized at a cost to the user, which limits the accessibility and therefore applicability of this tool. Next slide. So while the website advertising this tool doesn't actually report the cost of the tool without spending time engaging in a consultative discussion with the team, the research group had published another white paper demonstrating the budget impact analysis of implementing such a tool to predict postoperative delirium in Switzerland. On the basis of this paper, they reported an annual cost of 100,000 Swiss francs, which when converted into Canadian dollar is about $154,000 per year to use this tool. As you can see here, they predicted that the use of this tool would result in net cost savings as seen in the green bar in each of these scenarios. In a base case scenario, in the optimistic scenario, and pessimistic, when they account for the amount of cost that would be at cost to implement a help program, and then the amount of money that they would save by averting postoperative delirium, or the additional income that they could generate by freeing up hospital beds. Next slide. So now we'll move on to our critical appraisal using the ProBAST, which is otherwise known as the Prediction Model Risk of Bias Assessment Tool, which was developed to assess the risk of bias and applicability of prognostic prediction model studies. It evaluates 4 different domains: participants, predictors, outcomes, and the analysis of the study. Next slide, please. So the first probing question is whether appropriate data sources were used. I said yes, so ProBAST indicates that appropriate data sources would include RCTs, cohort studies, and nested case control studies. And all studies fell within this category as they did include 1 RCT, multiple cohort studies, and then they also included a prospective pre-post study. The second question is whether all inclusion and exclusions of participants were appropriate. I indicated this as probably not, Although the specific exclusion criteria of this particular study itself was appropriate, that being that they excluded individuals less than 60 years old, those without a reported post-operative delirium outcome, and those with preoperative delirium, the exclusion criteria of the studies that were used to make up the patient population for the training data set were likely problematic. Within the 8 selected studies, 3 had exclusion criteria for cognitive impairment, which was a variable that ended up in their prediction model. And this could have altered the performance of the prediction model in terms of the weight and impact of cognitive impairment on increasing the risk of postoperative delirium. So in terms of the risk of bias in the selection of patients, as a result of some studies having excluded individuals with baseline cognitive impairment, I think that the risk of bias can be graded as high. In terms of the concern for applicability, I think that there's low concern given that the included participants and setting were all appropriate to the study question at hand. Next slide. Now, in terms of the predictors selected, were predictors defined and assessed in a similar way for all participants? So because data came from so many different studies for the training data set, many variables were defined and attained differently. For example, in their supplementary data, they stated that some studies had reported the MMSE scores, whereas other studies reported in binary terms whether cognitive impairment was present or not. Although the authors did try to standardize the definition for cognitive impairment by defining it as an MMSE score less than or equal to 23, it's not guaranteed to be standardized given that we don't know whether the other studies reporting cognitive impairment in binary terms followed the same definition. Secondly, were predictor assessments made without knowledge of the outcome data? So because they used data that was from their systematic review and prior studies, this was not applicable to the collection of predictor data for the internal validation sample. However, when there were missing data in the external validation sample and predictor information had to be reconstructed, the researchers were blinded to the outcome of whether there was postoperative delirium. And were all predictors available at the time the model is intended to be used? I said probably yes. So in general, all predictors are theoretically ones that can be collected in the preoperative setting for patients. However, of note, if this model is being designed for the average clinician, for example, GIM performing a peri-op assessment or a surgeon who's discussing risks with patients, the information about underlying cognitive impairment, unless it was previously diagnosed, may not be readily available or accurately available to them. As such, the risk of bias is considered low here. Because the predictors, while they may have been assessed in different ways in the original studies, I think that the authors did try to attempt to define and assess them in a standardized way for inclusion in this particular study. In terms of the concern for applicability, similarly, there's low concern with the predictor definitions that they used. I felt that they were suitable for evaluating postoperative delirium risk, given that they were selected based on prior literature as well. Next slide. Now, evaluating the outcome. Was the outcome determined appropriately? All studies did use a validated tool for detecting delirium within both the training and external validation data sets. Secondly, was a pre-specified or standard outcome definition used? So they did use the DSM criteria for postoperative delirium as their pre-specified outcome definition and ensured that the assessment of delirium was made only in the postoperative setting. Were predictors excluded from the outcome definition? So yes, none of the predictors were included within their outcome definition. And then was the outcome defined and determined in a similar way for all participants? I said probably yes. So while the outcome was defined using the DSM criteria, as I mentioned, there was some variability in terms of how it was determined by way of using different tools in both the training data set, but also in the external validation sample as well. And was the outcome determined without knowledge of predictor information? I said probably yes. Technically, all data already existed prior to the start of the study, and therefore the outcome of postoperative delirium was obtained without knowledge of what predictors would be assessed in this particular study. However, it's possible that clinicians making the diagnosis of delirium would be aware of some of the predictor information. So for example, if the patient had pre-existing cognitive impairment, knowing the patient's age or what type of surgery they underwent, but not necessarily in the context of the study. Next slide, please. And then finally, was the time interval between predictor assessment and outcome determination appropriate? Probably yes. all predictor information can be obtained in the preoperative setting, although the authors did not necessarily specify when certain information was obtained or should be obtained for the purpose of the risk assessment tool. Some variables would not be time dependent, such as the type of surgery, but other variables, such as the CRP level, it's not really clear at what time frame within the preoperative setting it should be obtained. Otherwise, the authors were very specific in including only post-operative delirium cases and not capturing any patients that may have had preoperative delirium. Therefore, the risk of bias can be considered low, as all responses fell under yes or probably yes in this category. The concern for applicability, I also believe, is of low concern, given the outcome was well-defined through an acceptable definition using DSM criteria and in the appropriate setting in patient populations. Next slide. Now, moving on to the analysis, were there a reasonable number of participants with the outcome? So this study looked at both the model development and also did some external validation. So we'll break it up into two different sections here. So for model development studies, the number of participants with the outcome relative to the number of candidate predictor parameters should generally be greater than or equal to 20, meaning an events per variable of 20 or more. So in this study, it's a bit unclear how many predictors they truly started with, but in their supplemental data, they listed initially 15 variables that they strongly considered, some of which did not end up in their model. And so according to this, they should have had at least 300 participants with delirium, and they had 444 individuals in the development sample, meaning that this was the sufficient number of participants with the outcome. In terms of their model external validation group, it's generally recommended that the number of participants with the outcome is greater than or equal to 100. And in this study, they only had 87 patients with delirium. And so we would have to mark this as no for this component. Next were continuous and categorical predictors handled appropriately. So yes, they importantly didn't convert any of their continuous predictors into like dichotomized or categorized groups when they included it in the model. And were all enrolled participants included in the study. So they did ensure that they didn't exclude patients just on the basis of missing data. And that's important, and we'll go into that in our next slide. Were participants with missing data handled appropriately? So the authors did address how they handled the missing data in that they performed single imputation. And while it's good that they didn't exclude these patients, it's actually better to perform something called multiple imputation rather than single imputation. Essentially, in single value imputation, what you're doing is you're estimating the missing value by replacing it with just a single value within the data set for all individuals who's missing that piece of data. In the study, they used the predictor average for numeric variables, and then they used the mode for categorical variables based off other patients who had that data point present. And this can lead to underestimation of variability and therefore is potentially biased. In multiple value imputation, it actually estimates and replaces missing values many times with many plausible values estimating the missing value, and therefore this provides a more accurate estimate and reduces the risk of false positive or false negative conclusions. It's also unclear how they handled some of the missing data in the external validation data set. For things like ASA and the surgery risk, they indicated in their methods that they were able to reconstruct some of that data. But in the supplementary data, they also mentioned that they were missing data points for things like history of delirium, cognitive impairment, and the number of preoperative medications, though it's not clear whether they also performed single imputation here. Next slide. There was selection of predictors based on univariable analysis avoided. So although they initially reported that they considered 15 variables, they ended up selecting their 9 variables on the basis of them differing significantly between patients with and without postoperative delirium in their training data set after performing a two-tailed t-test. This is problematic and leads to bias as they didn't include all variables in their multivariable analysis and can lead to incorrect predictor selection as they are only relying on their statistical significance as a single predictor rather than in the context of other predictors. Secondly, were relevant model performance measures evaluated appropriately? So in order to gauge the predictive performance of their model, they assessed both model calibration and discrimination using the area under the curve. The calibration was done using 10-fold cross-validation with a total training data set. were model overfitting, underfitting, and optimism in model performance accounted for. So they did perform internal validation techniques, as I mentioned, with a 10-fold cross-validation in their model development. In their logistic regression analysis, they also performed a lasso regression, which allows each predictor effect to be shrunk differently and could have potentially allowed for exclusion of some predictors. And do predictors and their assigned weights in the final model correspond to the results from the reported multivariable analysis? I said probably yes. In the actual manuscript, the authors didn't specifically comment on the assigned weights of each of the predictors, but in their supplementary data, they did share the odds ratio for each predictor within their risk model. Therefore, the risk of bias for this analysis has to be graded as high, I would say, given some of the issues noted on the selection of their predictors and the handling of the missing data as noted in the previous slide. Next slide. So to summarize the critical appraisal for the study, the risk of bias is high when evaluating the selection of participants in the performed analysis, but was acceptable or low in the evaluation of predictors and outcomes. The applicability of the participants, predictors, and outcomes are all of low concern. And so overall, the risk of bias for the study would be considered high. Next slide. So to summarize, this is a new tool to predict the risk of postoperative delirium in surgical patients, though the selection of participants in analysis performed subjects the tool to risk of bias based on our critical appraisal. Further external validation with greater sample size and diversity of patients is required, and the clinical use of this tool, unfortunately, may be limited by its cost. I've also left my references in the next slide, and I'll welcome any comments or questions as well. Thanks so much.
Thank you very much, Victoria, for an excellent presentation. That was fabulous, fabulously done. Michael, go ahead.
Yeah, hi. I'm sorry my video is not working, but I did many, many, many years of preoperative consultations, and I worked on the assumption, as we do with universal precautions for transmission of infections, that everybody was at risk for delirium. And even though we had some data, and often you had to consult, 2 hours before the surgery and whatever, without having all the data, usually you had enough to say this person's at risk. And if you assume that everybody's at risk, you take the precautions in your pre-op and post-op recommendations or orders, depending on what kind of arrangement you have, to avoid those risks. So I'm not sure if you need an actual tool to predict the risk, as opposed to assuming everybody's at risk and take the precautions that you would normally do with somebody who you thought was especially at risk.
Yeah, I think the perspective that the authors had, and I think oftentimes around the discussion of why we should implement such a tool, is more so when we talk about like resource allocation and say, where do we focus our energy or our like monetary resources in terms of implementation of like a help program, or who do we actually highlight to involve a geriatric assessment, for these patients in the preoperative setting. Because I guess based on the prior literature, in terms of what actually is effective at preventing delirium, we may not be able to implement those things for all patients, although I guess in the ideal world, that would be the best case scenario if we could.
Thank you. Gabby has a comment in the chat. Did they compare the tool to the NSQIP surgical risk calculator? No,
they didn't. Yeah, they didn't mention that in the manuscript.
There were no comparisons. Victoria, I thought it was interesting that I haven't seen too many other tools give a relative contribution to the various predictors. Mm-hmm. And so that was nice in a way. And the example you put up had medications as one of the greatest, preoperative medications as one of the greatest influences on that postoperative delirium. So that was interesting in terms of potential low-hanging fruit if you could, easily manipulate medications.
Yeah, and perhaps
notwithstanding the risks of bias that you highlighted.
Yeah, and perhaps I'll just show I'll just share the screen for the odds ratio that they kind of established. This is essentially like what they found in terms of each of the risk factors that they accounted for. And based on the previous literature, actually, like in the past, cognitive impairment has more frequently been noted as like a high risk for postoperative delirium, whereas in the study, you can see that past delirium supersedes that. And I do wonder whether that's related to the fact that they had excluded a lot of patients without cognitive impairment in their initial training data set, and that it may have influenced like the weighting of the impact of cognitive impairment there.
Thank you. I'm a little less surprised at that, but there's a comment from Christina. I am also a bit concerned that the majority of external validation data were collected 10 years prior to the training data, and I wonder about how delirium diagnosis has changed over 10 years. And Christina also states, I do like that they said explicitly that this validation should be treated as a proof of principle to motivate further validation. Comment, excellent presentation.
Yeah,
so
I agree.
I'll just ask you kindly to stop sharing for 1 moment. Sure. We're 1 minute to the top of the hour. Victoria, final comment to you if you have another, something else to offer, to say?
No. No? Thank you.
Okay. Thank you very much to both our presenters today. Fabulous presentations. They are so great, the slides, the presentation, very, very grateful for the work. The evaluation, as an announcement, the evaluation was sent to all the guests' inboxes about 15 minutes ago. Please do complete your evaluations, and a lot of applause around the room. Thank you both again, and we look forward to next month's Journal Club. Have a great day.